Phần trình bày tiếp theo, Hiếu xin được phép giới thiệu phần trình bày chia sẻ của giáo sư Korff cũng đến từ Thụy Sĩ về những khái niệm và liệu pháp mới trong một vài bệnh não, động kinh và phát triển. Ở đây chúng ta sẽ nghe một khái niệm khá quan trọng, đó là bệnh não, động kinh và phát triển. Thầy Korff thì cũng đã hỗ trợ cho Bệnh viện Nhi đồng 2 trong suốt khoảng thời gian từ 2015 cho đến nay. Thầy là học trò của thầy B.E. Salon. Dạ, xin kính mời.
Come on, Dr. Ye. And thank you, Professor Lê as well. Professor Ye, thank you for the invitation. Thank you for the audience to be here today. Thank you, Dr. Trang, for the translation. I'm very happy to be here once again. It's always a pleasure to come back to Vietnam, and it's very nice to be here in this beautiful area. So the subject of my talk today is a bit in the follow-up of what Professor Abramovic just told you. It's about these specific, very rare, for most of them, and severe entities called developmental and epileptic encephalopathies, DEEs. Yes. Okay. So as you probably know, the DEEs are defined as entities in which you have drug-resistant, very severe and early onset epilepsy, and it's always associated with a very severe global developmental delay. The specificity of these entities is that the delay may be attributable to both the EEG or the epilepsy that's severe, and or to the underlying cause, which is in many, many cases, specifically when it starts in the first year of life, of genetic origin. So there are non-genetic causes in these EEEs, brain injuries, perinatal, hypoxic ischemic injuries, other types of diseases, but many, many of these diseases are of genetic causes, and there are now more and more genes that are known and that we look for when we start to investigate these children. I'm going to focus my talk, because there are many of these DEEs now, I'm going to focus on my talk on three of these DEEs, namely Dravet syndrome, West syndrome, and Lennox-Gastaut syndrome, that are the three iconic, most frequent clinical presentations of these DEEs. So Dravet syndrome, as you may have read this new definition that's proposed by the International League Against Epilepsy 2 years ago, is clinically manifest as recurrent clonic febrile seizures in the first year of life, mostly in the first year of life. It may go up to 20 months. And then rapidly after the first seizures start, the epilepsy starts to be very resistant, and there are no drugs that's really able to control 100% of the seizures. The other characteristic is that the MRI does not show anything, like some of these diseases, and that's in many cases there's an association with a mutation on SCN1A, which is a gene that codes for a sodium channel. I encourage you to read this paper by the International League Against Epilepsy, because it gives you the definition and exclusionary criteria as well. And I think this is the way to approach these diseases. The first step is to make a correct diagnosis, and then you can go up and start to think about what type of treatment you can use. So start in the first year of life, very recurrent, mostly focal seizures, and then epilepsy that's very drug resistant. So just like for the other of these diseases, as mentioned, the first step is to make a correct diagnosis. This is a tool that I encourage you to use if you can, and start reading this paper by Dr. Brunklaus in the UK, in Scotland. I'm not going to go into details, but he established a way to make a diagnosis and to have a correct differential diagnosis. One of the difficulties when you're confronted with these children is to know whether the first seizure that's often febrile with fever is going to remain just a febrile seizure that could be isolated, or if the child is going to go and develop Dravet syndrome. And he established this sort of score based on the age of seizure onset and on the so-called genetic score that includes the degree of amino acid conservation and some of the physical-chemical properties of the gene mutation to know whether the child is in a situation where the febrile seizure is going to remain isolated or if the child is going to develop Dravet syndrome. So this is an interesting paper. It's one of the new concepts that's been published quite recently on the topic. And I encourage you to read this paper. So back to therapies. The classical approach when you have a correct diagnosis of this Dravet syndrome is first of all to avoid using treatments that may be harmful for the patient. And these include sodium channel blockers like lamotrigine, carbamazepine, other types of anti-seizure medication. The other way is to use medications that are known to have some efficacy, even though it's not 100% of seizure control, but like valproate, clobazam, stiripentol, the association of the three of them, ketogenic diets can be useful as well, topiramate, etc. There are recent additions, and again, the aim of my topic is to draw your attention on what's being worked on, and mostly 3 drugs or 3 different approaches are being studied currently specifically for Dravet syndrome, that are quite interesting. The first one of them is fenfluramine. Fenfluramine is a repurposed anti-obesity drug. It was used to treat obesity in the past, and one of the pharma companies that started to be interested in this topic tried to develop an approach using fenfluramine in certain of these DEEs, and I'm going to come back on fenfluramine also with the Lennox-Gastaut syndrome. It's a FDA and European approved drug. We don't know exactly how it works. We suspect that it has anti-serotoninergic effects, but it's not quite sure yet, specifically in Dravet syndrome, but it seems to be working. There are 2 prospective placebo-controlled trials on which this is based, and I gave you the references. Yes, here. The first one was comparing the dose-dependent response in terms of seizures, 0.7 milligram per kilogram per day versus 0.2, and the second was to use higher and more sustained doses as compared to placebo in children who are actually already treated by another drug called stiripentol. Both drugs, both dosages were actually very well tolerated, and there was no valvular or cardiovascular problems, which was one of the fears that had been raised when the drug was used as an anti-obesity drug. It was not the case at these dosages. So the use of fenfluramine seems to be quite safe, and it seems to be efficient. There is a trial that is not yet started, but who will try to understand how fenfluramine is working in adults with Dravet patients as well. Okay, so this is another question, but this is to be followed up because the efficacy seems to be quite okay for children. The safety seems to be quite fine for children. These are preliminary studies, but they're quite convincing. And as you see here, they've been very well published, Lancet, JAMA Neurology. So this usually means that there's something quite interesting with these drugs. Quickly, on the 2 trials that have shown that it's safe and efficient, this is the first trial that showed on 78 patients that were treated with fenfluramine. It's a multidisciplinary trial in Germany. 85% of the patients remained on the treatment after almost 1 year of treatment, which means that it's usually well tolerated. And fenfluramine was associated with a reduction in the number of doses or dose of concomitant seizure medication in 2/3 of the patients. So after 1 year, almost 1 year, the drug seemed to be well correlated. This is the second trial in 150 patients, again, children 6 to 17 years. And again, 70 patients, more than 70% of the patients demonstrated at least a 50% reduction in the number of seizures. And again, there was no particular problems regarding heart tolerance. The last published paper was published last summer in 2023, 170 patients. Again, it's an international trial coordinated by our Australian colleagues. And here again, same type of results. More than 2/3 of the patients, 73%, showed a 50% or more reduction in the convulsive seizure frequency, which is quite high. And it's also very well tolerated in these children. None of them had a single heart problem. So several trials, well tolerated, seems to be efficient, and it needs to be used in clinical grounds. It's starting to be the case now. Interestingly as well, the incidence of sudden unexpected death in epilepsy patients was also demonstrated to be reduced in patients with Dravet syndrome treated with fenfluramine. As you see here on the two graphs, all cases of seizures, and then SUDEP was really significantly reduced in those treated with fenfluramine as compared with the rates that was calculated in another study years before. Another drug that's under study is cannabidiol. Cannabidiol is a derivative, is a substance included in cannabis, as you know. And here again, there have been a few international trials using cannabidiol in patients with Dravet syndrome. Here again, the safety seems to be quite excellent. No side effects in many, many children. And the seizure frequency was also demonstrated to be really reduced. This is, again, as you see here on this graph, more than 75% reduction. Some children even had 100% of reduction and 100% of seizure control for a few weeks during the trial. To the point that these two drugs are now considered as the second choice when the diagnosis of Dravet syndrome is made. Usually we recommend to use valproate as first choice, and then fenfluramine and cannabidiol are considered as second or third choice. So this has been now included in the algorithm that's treatment that's proposed by, again, international consensus in Dravet syndrome patients. And then, as Professor Abramovich just told you, the third way to approach Dravet syndrome is the so-called antisense oligonucleotides. And one of the trials that have started now, there are a few of them, but this trial is now completed. It was a phase 1 and phase 2A safety extension study in patients with Dravet syndrome, children and teenagers. And these patients actually benefited from one single intrathecal injection of this specific ASO targeted to a specific mutation on SCN1A. And then the authors compared single versus multiple ascending doses. So either just one injection or a single versus multiple ascending doses. As in many of my slides today, unfortunately, the results have not been published yet. So the trial is now completed. There's no enrollment. But I ask you to follow this up because this is going to be very likely to be interesting. At least you know the preliminary results of the study that's now completed. And also other drugs are to be followed. You may have heard of soticlestat or other type of different medications that act for some of them on glutamate receptors or again on serotoninergic different receptors. There are other drugs, and for these trials, I encourage you to go and check regularly on the website clinicaltrials.gov. It's a US centered website that on which you are supposed to announce your clinical trial. So all of the trials that are starting in the world are announced in this, on this website. And there are many, many things going on the developmental and epileptic encephalopathies. So go regularly, check on clinicaltrials.gov if you're interested in a topic, because many, many things are going on. Okay, I'm not going to go into too many details, just to see here that there's another gene therapy that's under investigation. It's an adenovirus delivered gene therapy, and there are 3 different branches, one in the US, one in the UK, one in Australia. They're all currently recruiting patients. So if you know patients that could be interested in participating, you may ask them, for example, if they would be ready to go to Australia and see if they would be ready to enroll your patients. Okay. So now going to the second syndrome, infantile epileptic spasm syndrome, or formerly called West syndrome. A bit less going on. Again, if I go back to this ILAE paper in 2022, the colleagues have given new ways of approaching the diagnosis, the necessity to have the interictal hypsarrhythmia on EEG. The age of onset has been extended a little bit to up to 24 months. But as you know, spasms usually start in the first year of life. The therapeutic classical approach is to use ACTH or prednisone versus vigabatrin. You can also use ketogenic diets, various types, topiramate, other drugs. I kindly ask you to refer to different websites, because there's been so many studies published on the treatment of West syndrome that it's not the purpose today to summarize everything on the topic. But here too, there are a few things. Here, it's just a recommendation. You will have my slides after the talk. I'm not going to spend too much time on that. But here again, cannabidiol has been used as an add-on therapy in children with treatment-resistant spasms. This is a quite recent paper published at the beginning of this year in 2024. Just like with Dravet syndrome, cannabidiol seems to be quite efficient with a few patients that were seizure-free, or at least more than 50% of the spasms disappeared in 12 of the 28 patients that were treated. So cannabidiol may be an interesting add-on therapeutic approach in children with infantile spasms. And now this is another study that has just come out from the French team, Stéphane Auvin in Paris and our colleagues from Marseille. And they actually compared different ways of approaching infantile spasms, either with a serial approach using first vigabatrin and then steroids and then ketogenic diets, each time as a next step, comparing to using vigabatrin and prednisolone initially, and then after 14 days, in case of non-response, to add the ketogenic diet. So to use a more combined approach and more aggressive approach. And the combination of these different approaches seem to be more effective in achieving seizure freedom than the sequential treatment on the spasm-free rate at 1 month. So 1 month is a very short follow-up, but nevertheless, the addition of drugs together and initiation of the ketogenic diet after a few weeks only, 2 weeks, seem to be quite efficient and more efficient than using the classical approach. So maybe something to be followed up. This is a partly retrospective study, so the method was not really designed to be absolutely sure of the results, but I'm sure that this is something to be followed up, and that more results could be published in a few months. And now, the last syndrome I wanted to spend some time on is Lennox-Gastaut syndrome. Lennox-Gastaut again, is a bit of a basket, but here the idea of the ILEA was to precise exactly what we understand when we use the term Lennox-Gastaut syndrome. And here, again, it summarizes the fact that you need to have tonic seizures, and in addition, at least one other type of seizures, including atypical absences, tonic-clonic seizures, etc. The EEG is quite at least suggestive, if not specific, with these less than 2.5 hertz spike wave complexes, and the onset is always before 18 years. Again, just like with the other DEEs, the seizures are very resistant to all the drugs that we use currently, and there's a mild, usually profound intellectual disability associated. So here too, the classical approach includes the use of old and more recent drugs such as felbamate, lamotrigine topiramate, valproate, rufinamide, other drugs. And there are recent additions, again, cannabidiol is the object of a series of studies, and fenfluramine, again, the usual suspects, currently the object of quite an interest from the pharma companies. So I'd just like to remind you or draw your attention on a few papers again. This is a New England Journal of Medicine papers published 6 years ago on 200 patients, showing that the addition of cannabidiol was efficient on drop seizures in Lennox-Gastaut patients. Another part of the similar study showed that it was efficient in drop seizures, but also in the total number of seizures. And that the long-term safety was demonstrated also in this trial that observed patients during 3 years. So cannabidiol, again, seems to be quite interesting. Although, if you go to the Cochrane library and you enter the term Lennox-Gastaut treatment or anti-seizure medications, quite interestingly, no single trial has reported the complete seizure cessation in these patients. So you may use a combination of treatment, you may use new treatments. It remains very refractory, whatever you use. And quite interesting, if you really look into the evidence, clobazam, for example, has never been shown to reduce seizures, at least officially. It's not been shown to reduce seizures, okay? Cannabidiol, the two trials that I showed you, including the one that was published in the New England Journal and the other one in Lancet, they have been included in this Cochrane library analysis. And again, the authors of this review considered that these two papers, even though they have been published in very good journals, the methods was not clear enough to be sure that the proportion of responders was really significantly better, higher than those who were not treated for cannabidiol. So again, all of these results, even if they have been published in very good journals and that the results as presented are quite convincing, must be taken with caution. Okay, so this is an important message I want to show you, because if you go back and you really analyze the methods, even for these studies, it's not always very convincing. So be careful. You can use it maybe if you want, but you should not expect 100% seizure control for now. Fenfluramine, just like with Dravet syndrome, again, it has been shown to be efficient and safe. Again, this is a quite recent paper, 2022, comparing 263 patients with Lennox-Gastaut. There was a phase 3 study using different dosages, and it was shown that at 0.7 milligram per kilogram per day, the efficacy was greater than if you use a placebo. So it seems to be efficient, yes. And here again, tolerance was really good in terms of heart disease. So this is maybe the most important point. I can go a bit quicker because this is a confirmation what I showed before. And again, soticlestat, the one that I showed you before, that's currently in use for Dravet patients, is also the object of a study in Lennox-Gastaut. So this paper compared actually soticlestat, this new cholesterol hydroxylase inhibitor, in Dravet patients and Lennox-Gastaut patients. And as you see here, the rates of drop seizures was lower in Lennox-Gastaut patients treated with this new drug under investigations. Last but not least, just before concluding, I would like to remind you something. DEEs is not only about seizures. And most of the trials actually that have been going on or are current actually try to see if the control on seizures and epilepsy can be better. But of course, non-seizure outcome must also be addressed when you treat these patients, because seizure is just one part of the clinical picture. But the clinical picture is much more severe than just seizures. You know, they also have an incredible delay. They have neurological problems. They may have balance problems. They may have sleep problems. They have all sorts of things. So it's not only about treating and controlling seizures. It's also about non-seizure outcomes. And interestingly, I have 2 more slides. This starts to be the object of a study. This paper was just published before I came to Vietnam, July 4, so 1 month ago. And as you see, non-seizure benefits are also observed in patients treated with fenfluramine. So again, please keep this reference, keep this in mind, and keep in mind that DEEs are seizures, but also beyond seizures. More specifically, some of the patients treated with cannabidiol also has been reported to be improved in their cognition and emotional function. And so again, this is a very recent paper, 2024, showing that cannabidiol and fenfluramine may have good effects on seizures, but also on non-seizure outcomes, which is a very important point in these children. Time out. Come on. Thank you very much.